All right, guys, it is 12:01. I am Dr. Christopher Williams. I appreciate everyone's time and thank you for logging in for the webinar. I look forward to educating, informing, and answering any questions that you may have. This is just a brief overview of what we'll be talking about, primarily focusing in on the Regenexx product, looking at our culture and non-culture expanded stem cell product, and also we'll touch base on our PRP therapy as well and kind of talk about some of the differences and nuances and also mention some IV therapy, what sets Regenexx apart, and also who may be a candidate for these types of procedures as well. So really this presentation or webinar is really for anybody that fits into one of these buckets. Are you somebody that is active, wants to maintain your activity? Are you somebody that's struggling with chronic pain? Or somebody that wants to be proactive? Maybe you don't have any issues that are pressing right now, but maybe you're interested in cell banking or storing your stem cells for further use in the future when issues may arise, as they always do for anybody of us that are fortunate to have years to come. So what is Regenexx? Regenexx is a company that was founded in 2004. We have over 100 different providers throughout the world, as well as most of those located primarily in the United States. We do have physicians that are located in Europe, in India, and several different other countries also. And we operate on the premise of doing biologics only for musculoskeletal conditions. We don't do treatments primarily for erectile dysfunction or hair loss. Some may dibble and dabble in things on the side, but we are orthopedic and musculoskeletal experts that utilize biologic therapy. So what that means is things like PRP, stem cell therapy to treat issues. And we also are very well founded in research. So the goal of our treatments and how we approach things is to always approach it from a evidence-based approach to see what works, what doesn't work, and how can we make things better and inform the public about these treatments as well. So we publish a lot of research. To date, we published over 40% of the total stem cell therapy research on treating orthopedic issues as well. And that's always something that we're trying to expand upon and further the field to make sure we're coming at it from an evidence-based approach also. It's a little bit about myself and the other physicians at our practice down in Cayman. So I'm Dr. Christopher Williams. I'm originally from Jacksonville, Florida. I'm an Air Force veteran, served time in the 2000s, stationed in Kuwait, in the UK, Texas, Mississippi as well. I currently have a practice in Atlanta, Georgia. I did all of my training at Emory University in Atlanta, Georgia. My board certification is physical medicine and rehabilitation. We're musculoskeletal experts, and also did fellowship training in orthopedics and regenerative medicine in Colorado as well. We have 6 other physicians that rotate through, 2 of them in Colorado, 1 in Baltimore, 2 in Florida, and 1 in California, the LA, Southern California region as well. All of us have had fellowship training and extensive training and expertise in orthopedic treatments with cellular therapy as well, and have published a degree of research on the topics also. All right, so let's jump in here and what can be treated. So as I mentioned, we focus in on orthopedic treatment. So that means your musculoskeletal system, things such as ligaments, tendons, bones, joints, cartilage, etc. So when we talk about the spine, we're commonly treating things such as pinched nerves, disc herniations, disc tears, sciatica or radiculopathy, torn disc, etc. Talk about the shoulders, that may be some common things as a rotator cuff tear, which can affect about 70% of us over the lifetime. Labral tears, arthritis, instability or subluxations of the shoulder as well. Also, hand and wrist with the CMC or thumb joint being the most common joint in the body that does get arthritis. We commonly treat arthritis in the hand and wrist, nerve issues such as carpal tunnel syndrome, also at the elbow with cubital tunnel syndrome, and also inflammation of tendons and ligaments around the wrist and the elbow, one of the common being tennis or golfer's elbow, which is very common. In the knee, which is probably the most common thing that we treat, is particularly with arthritis. We also treat tears of ligaments such as the anterior cruciate ligament, meniscus tears, and also tendinopathy of the patella tendon or jumper's knee also. And then the hip, some of the things that we commonly see are hip arthritis, hip labral tears, avascular necrosis of the hip, and also tendinopathy or bursitis or gluteal tendinopathy of the hip as well. Then we also treat conditions of the ankle and foot, being arthritis, bunions or big toe arthritis, Plantar fasciitis, Achilles tendinopathy, and sprains of the ankle ligaments and tendons that live around the ankle joint themselves also. So pretty much from soup to nuts, from the base of the skull and the cervical spine all the way down to the big toe, anything revolving around orthopedics and musculoskeletal injuries. So one of the primary treatments that's been around probably since about 2007 is something called platelet-rich plasma. And what platelet-rich plasma, or PRP, is where you take someone's blood, and blood contains a couple of different things. Primarily, you have red blood cells, white blood cells, platelets, and plasma. And the platelets are one of the initial healing cells in the body when you have an injury. My patients always give them the same example to help them kind of visualize and understand what a platelet is and what its function is in the body. If you can imagine, if I'm running down the street and I fall down and I skin or scrape my knee up, the first thing that happens is I'll bleed, and then I get a scab that forms. And that scab is 100% platelets, right? Those platelets then produce about 2,000 different growth factors and exosomes that promote tissue healing and regeneration. So when that scab comes off, and 2 to 3 weeks down the line, the tissue underneath is healed. The problem in our musculoskeletal system, all the areas that we just talked about, the joints, ligaments, tendons, bones, cartilage, all of those things, they have virtually no blood flow or very little blood flow. So when we herniate a disc or we tear a meniscus or damage the cartilage, it turns into a chronic degenerative process that doesn't heal. So the premise with the biologics, in particular, we're talking about with PRP, is that we can take the platelets from the blood and concentrate them and then precisely inject them into the damaged areas to get a healing response to occur. And that's what makes them unique as well. And what we do, which is different to Regenexx, is we have a flexible lab platform. So if you go to an orthopedic clinic down the street, when they're doing PRP, they're going to take your blood, put it in a bedside centrifuge, and it's going to spit the product back out in about 15 minutes, and then they're going to inject it in. That may be about 2 to 4 times concentrated platelets. When we're doing these procedures, we concentrate things based upon your pathology. Every treatment plan is individualized. So for some people that have severe arthritis, we may be putting 20 times concentrated platelets in their knee, maybe 8 to 10 times concentrated, or in their ligaments or tendons, depending on what the pathology is. Everybody gets a unique treatment plan, and we can do that because we use a laboratory where everything is processed by hand as well. And it matters. When we look at the data and look at studies that show that PRP works versus when it doesn't work, it typically comes down to a dosing problem. And the best way I can get people to understand this is that if an adult such as myself, I have a fever, I cannot take infant's Tylenol or infant's Motrin for my fever. It won't work. It's a dosing issue. I have a certain body mass, and I have to have the appropriate dose to have the desired clinical outcome. And these treatments, such as PRP or stem cell therapy, they work like medicinal things. They work in the same vein as drugs. And so you have to have the appropriate dose to get the desired clinical outcome and response. So dosing matters, and that's what kind of sets Regenexx apart when we're talking about biologics. So that's PRP in a nutshell, right? Same-base stem cells is something that we can do in the United States, right? So we used to do culture expanded stem cells in the United States up until about 2008. The FDA issued a stop injunction and said, you can't do that. You're creating a drug when you do that. So we had to stop doing that. So what we can do that is compliant at this point is do non-culture stem cells. So that's where we take your bone marrow or your adipose or fat tissue. We process it in the laboratory for 2 or 3 hours. And then we have a concentrated stem cell product that we can then inject into the damaged tissues, whether that be into your joint, your cartilage, your ligaments, your tendons, etc. And we then also can add in some PRP and platelets with that product. It is not cultured, and it's all used within the same day to be FDA compliant. It contains stem cells, and it can be a great product depending on what we're treating. If it's very mild issues or you have one joint with arthritis, it is a phenomenal product that can have significant outcomes of improvement as well. Now, when we talk about cultured stem cells, that's a little bit different. As I mentioned, what culturing means is that when you talk about bone marrow, for example, when we take bone marrow out, bone marrow contains several things, just like blood. But bone marrow contains platelets, red blood cells, white blood cells, And it contains three types of stem cells, one being hematopoietic stem cells that produces all the blood cells in your body. And it contains mesenchymal stem cells as well, or MSCs, and these produce all the tissues in your body. And so MSCs or stem cells are very different than platelets because MSCs or stem cells can actually turn into new tissue, which gives them the highest healing potential of the biologic therapies that we offered. And when we do culturing of the stem cells, we actually pull the stem cell out of the bone marrow, and in the laboratory, we grow it to millions of cells. So when we compare this to the non-cultured stem cell product, we typically are injecting 1,000-fold more stem cells. For example, I had a patient that I just treated. I injected about 70 million stem cells, actually 93 million stem cells into his ankle. When we're doing the non-cultured stem cell treatment, we're probably on average injecting somewhere around about 100 to 200,000 stem cells as well. So the magnitude and multiple of stem cells that we can then use to treat multiple different issues is significant. So that's kind of primarily the difference between the culturing versus non-cultured stem cell. Stem cell banking. So that's a great service that we can provide here by being able to essentially cryopreserve your stem cells for you to use at a later date, right? So why is that important or a good opportunity for you? When you are younger, as we get old and older in age, our numbers of stem cells in our body commonly decline with age. The quality of the stem cells is very heavily dependent upon the health of the individual, the genetics, what medical conditions they have, if you smoke tobacco, etc. The quantity is very dependent upon age as well. As we get older, that quantity continues to drop. So we have a lot of patients that bank their stem cells when they're younger. So when they have issues that come up when they get older, they have a more bountiful harvest that's there and waiting, frozen or cryopreserved to be used. We see this with athletes or weekend warriors or people that just want to be more proactive as well. But when we do these treatments and we have cells that are left over, these cells are banked as well. So that way, in 4, 5, 6 years later, if you have another issue that comes up, or you need a tune-up for an X, Y, and Z issue, you have the cells ready to be utilized. So that's some of the benefits of cell banking. It's an insurance policy for you to use at a later date. So Regenexx Cayman, which is in the beautiful Cayman Islands, which is a beautiful destination. We'll talk about that a little bit later. But the clinic here was founded in 2011 as well. So we've been doing these treatments longer than anybody in the world. We did the first stem cell culture procedure into the disc and the spine in 2006. We treated the first knee for arthritis in 2005 with culture expanded stem cells as well. So been doing these treatments for quite some time. All right, so these are some of the things that we have talked about, some of the main differences with doing treatment with Regenexx Cayman culture expanded stem cell product. The quantity of cells is significantly more, which allows us to be able to treat more than one area at a time. That's really the biggest hamstring issue that we have when we don't use a culture stem cell product. You can only treat about one area at a time and have to wait at least 6 to 9 months before you can think about treating another area. And then also the cell banking, right? We can then store our cells for later utilization as we may need them. So we have a couple of cases here that we'll kind of go through to help kind of give you a visualization of some of the things that we expect before and after treatment. So this is a patient of mine that I treated his lumbar spine. He's a professional athlete, basketball player. He's having pain going down his right leg or sciatica, and also a lot of lower back pain. So on the left here, what we can see is he had some tearing of the disc here and here with a significant disc herniation at L5S1. As well, he was starting to get some disc degeneration where it's starting to flatten out a little bit at his L5S1 segment. So we treated his low back and then repeated the MRI afterwards. And what we saw is that the herniation significantly improved as well in his functional standpoint. From a functional standpoint, his pain and function significantly improved and completely resolved. He did well for about 6 years. He's been doing fantastic. This was about 6 years ago we treated his low back. All right, so this is a great example of a shoulder and a rotator cuff tear. The most common tendon of the rotator cuff, which contains 4 different tendons, is the supraspinatus. In about 75% of cases, when we talk about a rotator cuff tear, it's going to be of the supraspinatus. And the supraspinatus is a muscle that lives on the top of the shoulder, and it comes down like a bird's beak and attaches to the side of our upper arm here called the humerus. This white that we see here is all fluid. And then we see a big white gap within the tendon, and that's a tear of that supraspinatus of the rotator cuff. So this patient was treated, did phenomenal, and then on post-treatment imaging, meaning after we did the treatment, we got an MRI to check on the status of the healing, and we can see that that rotator cuff tear completely healed and resolved. So that's something that we can commonly see as well with these treatments. This is another example of a hip. So this is the patient's femur right here. The hip is a ball and socket joint. The ball being the head of the femur, the socket being the pelvis, and they connect together to form the hip joint proper. And then you have something called the labrum that grabs this ball of the femur like a plunger, right? And you can tear that. And that little white ditzel right there in this triangle is the labrum, and that's to tear the white little structure there. So with precise injections into that labrum, you can get the labral tear to heal and avoid surgery also. So this patient did phenomenal after stem cell treatment for the labral tear as well. All right, so this is a slide that's comparing kind of what we do in comparison to surgery. So this is Regenexx therapy in comparison to surgery. So with Regenexx, the procedures that we do are clinic-based. You are going to have the procedure in a procedure room and not in the hospital or ambulatory surgery center. Why is that important? Because it helps keep the cost down. If anybody's had a procedure, we know that there's a facility fee, hospital fee. These fees vary from $4,000 to $15,000. So it raises the cost of the procedure up. Then we do things with needles. We're not cutting the tissue open. We're precisely using image guidance to inject the structures to get a desired clinical outcome as well. And that's usually going to be C-arm or fluoroscopy and high definition ultrasound. So that helps with recovery as well because there's less tissue trauma. Post-procedural pain is going to be significantly different. We do have some significant pain, but it's usually going to be very short-lived, from anywhere from 24 to 72 hours needing to take pain medications. And most people by day 7 after treatment, they're kind of back to baseline in terms of their pain response. Next, we have risk of complication. Every procedure has a certain risk of complication, but when we look at the surgical risk versus what we do, it's really, we're talking about 1% or less versus 3 to 5% typically, depending on what the procedure is. So things like blood clots, hematomas, infection and bleeding and those things of that nature, nerve injury, these things with what we do are very rare and uncommon. The recovery period, which means getting you back to the things that you want to do, whether that be skiing, basketball, hiking, running, or just being able to get up off the couch without pain, right? Or ride on a long flight without pain is much quicker. We typically see most people start to have significant improvement from the procedure at about 6 to 8 weeks out, and then things start to plateau at about 12 to 16 weeks, depending on what we're doing, maybe on the shorter side of that with PRP, but with stem cell therapy, it may be out to about 6 months as well also, but the recovery is not that long, and the recovery period in terms of the pain response is much faster, meaning you're back to kind of baseline and doing your baseline activities much quicker. And then the tissue, so what's happening? We all know is when you have surgery, we're cutting out the damaged tissue and either cutting that out or replacing that with a prosthesis or prosthetic or artificial device, whether that be an implant that's metal, titanium, ceramic, etc. What we focus on is trying to heal and decrease the inflammation and damaged tissue. So we're not removing any tissue. We're trying to heal and work with the tissue that we have. Why is that important? When you can keep your native tissue, your risk of long-term problems can be much better. So an example that we like to talk about is when we talk about patients that have had an ACL tear, right? When you have a tear of the anterior cruciate ligament of the knee, you have ACL reconstruction. About 60% or more patients after the ACL reconstruction have arthritis at 10 years. So when we can heal that ACL with your own ACL, not having to take it out and put something else in there, we're able to get the mechanics, what we call the biomechanics of the knee preserved and prevent the risk of the arthritis development over time as well. Let's briefly segue into umbilical versus bone marrow stem cells. So a large percentage of patients, and you may be one of them, always have heard or are hearing things online, social media, or the news, friends, family, that, oh, your stem cells are too old, you need to use young stem cells. Well, that's not necessarily true or very true at all, right? The quality of the stem cell, regardless of age, is dependent upon the health of the individual, right? When we have patients that have rheumatoid arthritis, diabetes, they're chronic tobacco or smoker users, they use excessive alcohol, they are morbidly obese. All of these health conditions, they take chronic steroid use, affect the quality of your stem cells. So we modify and can work on your habitus and the things that are modifiable that we can improve, the quality of your stem cells are going to be much, much better. And then the numbers. So that's something that also is very relevant to this. When you're doing a non-culture stem cell product, which is what we do in the United States, using umbilical stem cells will yield a significant amount more of stem cells. But when you're doing the cultured product, we're able to grow your stem cells. So that becomes a non-factor as well. So the other key thing here is when you're using umbilical stem cells, there's always a risk of having an autoimmune rejection reaction as well. These typically are more transient and not severe usually, but they are not your stem cells and they can invaginate or engraft into you as well and cause an autoimmune response reaction as well. So that's kind of the negative or one of the downsides of using umbilical stem cells also. All right, so this is a brief slide. It kind of talks about one of the things we talked about, which is when can you get back to activity as well. It varies depending on your pre-treatment level of activity. Like if you had been someone that hasn't been doing much for the previous 6 months and you were barely walking around, it's not going to be realistic to get back to playing some pickleball in 6 weeks after treatment, right? You're going to have to do a lot of physical therapy to work on strengthening stability and your biomechanics. But if you're somebody that has been active and we're just looking at getting back to golfing or tennis, it's going to be about 6 weeks or so before you start to do some organized activity. And then we continue the recovery after that as well. Really focusing in on long-term success is really going to be key with incorporating good biomechanical rehabilitation work as well. That's how we get long-term success. The treatment is fantastic, but we really have to work on the biomechanics by doing good qualified physical therapy as well. Is very critical and important. So why patients choose Regenexx Cayman? We've kind of talked about these things, but just kind of go to run through the list here. The dosage is significantly more than what we can do in the United States, about 5,000 times more. We can treat multiple joints for that same reason. We're able to treat severe issues and conditions that are usually going to be surgical candidates. So we're able to help people to avoid surgery that may not have been able to do that otherwise. As well, banking of stem cells, which is phenomenal, cryopreserving your cells to be able to be used for when you need them, is huge. And these are your own stem cells. We have the capability to use umbilical stem cells, but our orthopedic treatments are done with your own stem cells, either from your bone marrow or from your own fat tissue. And each plan is tailored for you. We don't use a one-stop shop. You come in with knee pain, we just having a nurse practitioner or mid-level, not to say there's anything wrong with them, but that's not our model. We have the physician do an examination. We look at the imaging. We come up with a plan designated specifically for you and your injury. And we don't do anything blind. Every patient has image guidance for the treatments. There's been enough research to show that when you do blind injections, the likelihood that you actually hit your target is about 65%. If it's me and my money and my body, I don't want to take that risk and gamble, right? I want to make sure that the provider is using image guidance to get the treatment where it needs to go at. In this day and age, in 2026, there's really no reason to be doing blind injections. Research, we're always publishing research. We published about 3 papers this year alone on culture expanded stem cell treatments for the low back, the shoulder, and the knee. I have one pending here for the hip also, and we're always trying to push the envelope to see what makes these treatments work better. We're all board certified in the United States and fellowship trained as well. And then the Cayman Islands, right? Who doesn't want to have a treatment? There's phenomenal destination location, extremely safe, phenomenal restaurants, beautiful beaches, has a slew of resorts, everything from the Ritz to the West End to the Hilton and the Holiday Inn, depending on your preference of where you want to stay at. There's a lot of Airbnbs as well. This link will be a hyperlink that you can access when we send you the PowerPoint via email through YouTube. So we've had several professional athletes that we've treated over the years. And Ryan Tannehill is just one of those athletes that has given us a testimony. You can hear his treatment process and how his treatment went in his own words. So that's something that we'll be able to provide you via email. We also have information on virtual consults. So typically how this works logistically, because we have treated patients from over 55 different countries, we do telehealth or virtual consultations. So you're able to provide a convenient way for yourself, your family, or friends to be able to talk directly with the physician, where we go over your imaging, talk about what has led to this issue over the years, and then come up with a treatment plan based upon those things together as well. So it's very convenient for you. It takes about 20, 30 minutes to do, sometimes 45, depending on how many issues that you may have. But we would love to sit down and talk to you about kind of your problems and issues and how this may be a good fit for you as well. Currently, we do have a summer special that's going through the end of September, where we're providing compensation and a discount on the treatment, a US $1,000 as well, to be used for airfare also. And we have a couple different ways you can reach us and contact us. So our email is info@regenexxcayman.ky. We also have a US free toll-free number, 877-211-3834 also. So if you have any questions, you can definitely shoot us an email there. Happy to chat with you as well about those. And like I said, we'll get this PowerPoint presentation over to you guys as well. So I think right now I'm going to segue over to questions as well. So let me see here if we have any questions. All right, so there's the Q&A section here, guys. If you have any particular questions, I will answer them here, and I can also allow people to answer any questions live as well. So the first question that we have here is from Dan, and Dan wants to know, can PRP use on injured muscles? So great question. And yes, there's a lot of research on PRP utilization for muscle injuries, whether it be acute or chronic. Typically now we're doing a concentration of platelet-poor plasma and some PRP to treat acute muscle injuries, whereas more PRP for chronic muscle injury. So that's been a lot of research, and it's a hot topic in research in treating hamstring tears, adductor tears, or calf muscle tears in athletes, and what's the best way to treat them. And PRP has shown to be a very effective way to treat these issues. So very good question. All right, so we have the next question from Randy. How long does the stem cell expansion take? That's a good question. Logistically, how it works is, so you come down to our site in the Grand Cayman, and then we do the aspiration or extraction of the stem cells. And it takes us about 3 weeks to culture expand the cells. And then we have about a week of testing for viability. We also look at endotoxin testing and sterility testing. So we always tell patients that you can come back as soon as 4 weeks after the aspiration to have these stem cells used or injected. It doesn't have to be 4 weeks. It can be 4 months or 4 years. We have patients that have had cells in storage for 12 years now. So it just depends on your overall need and availability, but at least 4 weeks is the minimum. Good question. All right, next question. What are the different ranges for cost of procedure, and what is the cost of cell banking? Good question. So PRP procedures can range in terms of cost all the way from anywhere from about $1,500 upwards to several $1,000s, depending on what's being treated. And stem cell therapy, depending on if it's culture versus non-culture stem cell therapy, non-culture stem cell therapy can range anywhere from about $7,000+, depending on what's being treated. And culture expanded stem cell therapy is broken down into 2 parts. The first being for the bone marrow aspiration and culturing process, which can be about $11,000. And then depending on what structures are treated, the second cost is priced out if we're treating 1 area versus 2, 3, 4, 5, 6, 7 areas. The cost of cell banking by itself is in that first portion of the treatment. And for patients that keep their cells in storage year over year, there's an annual fee of about $400 for that as well. So very good question. But if there's any question that you want to know about pricing specifically, we are happy to give you a itemized out invoice for a specific indication for treatment. Can you bank and culture PRP? We do not culture, but we do bank PRP for use and growth of the stem cells as well, and to use for when the patients come back. But it's usually a form of PRP called platelet lysate that we're actually storing or banking per se, but you can't culture PRP because it's PRP or the platelets are non-cellular and you can't grow non-cellular things, but we do bank them to use when patients come back to save them from having to get another blood draw. Good question. Next question. I have clients that have banked their MSCs from when they were young. If these folks want to have treatment at your facility, can they use the cells that they have already banked, and how would that transportation of the cells work across international borders? Yeah, that's a great question. And short answer is it should not be an issue, but it also would depend on the facility that they're banked at, how old the cells are, if they're actually their cells or relative cells. But we typically do more of using your own cells, but that's something that we've explored and had patients inquire about in the past as well. As far as importing the cells here, that's not an issue. There's a tax on that, but we cannot import cells from here to the United States. The FDA does have a problem with that, but good question. All right, next question. You mentioned both bone marrow and fat cells. Do you use both or just bone marrow? We use both. The vast majority of the stem cell therapy treatments that we do is going to be with bone marrow. It's just tried and true and more well studied. The data for bone marrow is about 75% of the published research on stem cell treatments for orthopedics that has been published to date. So we kind of know what we're going to get. Sometimes we use fat tissue if patients have issues that we can access their bone marrow, or if they have a preference as well. So just depends, but we do a lot more bone marrow just because the research is much more abundant that shows that it does work and has a better and longer track record as well. Good question. All right. How long can we keep stem cells in banking? Yeah, there's really no time clock on that, because when we do use the stem cells, when we take them out of cryopreservation, we check them. We check them for viability to make sure the cells are still living and able to grow. And we grow them and culture expand them from that point that they're thawed out. And we also check them for viruses and toxins and things of that nature as well. So I think we have patients that have had cells here since 2011. So several years that are still frozen and able to be utilized as well. Good question. Do the stem cells lose potency over time? They can if they're not, two things, if they're not preserved correctly, meaning that if there's fluctuations in the temperature, if there's power outages, et cetera, the cells are thawed out, then frozen again, the cells can actually die. Or if the cells are not thawed out properly, meaning if they're rapidly thawed, which we see these things happen a lot of times in clinics and labs that are not experienced. They thaw the cells out by rubbing them in their hand, by heating them up. We have a thawing protocol that actually is done over 72 hours as well here. So you have to be able to thaw the cells out appropriately or they will die. So yes, there is a certain way that you need to do those things. Good question though. Next question is, someone had multiple problems in the shoulders, such as labral tear, plus a tear in the distal subscapularis, plus bursal edema. Would you do multiple injections? Absolutely. When we do these treatments, we treat everything. So we don't just treat one structure, and everything that we treat is included in the price for that structure typically. There may be some caveats here or there, but when we treat a shoulder, we do a full assessment and we treat everything that's there, whether that be the bursa, the labrum, the rotator cuff, the other joints, the AC joint, everything that's involved that's causing an issue, because our job is to have this to be as much of a one and done situation as possible. We're not trying to have a revolving door of treatments for the same problem. So we want to take care of this and give you the best likelihood and highest chances of success. So yes, we treat structures, all the structures that are pathologic and have damage in them as well. Good question. How long is the treatment supposed to last? That varies. We're publishing our long-term data now. Like I said, we just published long-term outcomes on intradiscal treatments. So patients that had tears of their disc or degeneration in their spine. And we looked at how they did over a 10-year period. And people did great. There was only one patient out of all the patients that we looked at the 10-year point that was not doing that good. So all of them were able to avoid surgery as well. So Then we did the same thing for our shoulders. We followed these patients out to 6 years. Patients were still doing phenomenal as well. It really depends on the wear and tear that you put the joint and stress of the body under. The body is a machine. I always tell patients, think of it as a Bugatti, right? If you have a very expensive luxury car, which is your body, and you drive it 1,000 miles a day, or you drive it 10 miles a day, that's going to vary the maintenance that you have to do and the upkeep that you have to do. So we get patients, they get back to marathons and skiing, et cetera, et cetera. None of these treatments preclude you from getting a new injury, and they don't buffer you from not being able to do the normal wear and tear and maintenance that you have to do for upkeep of anything as well. And that's your long-term therapy and rehab to make sure you're having the strength and stability to stay active. So, but most of these people that have these treatments do well for several years. Good question. What would be the approximate cost for a torn rotator cuff / shoulder tendonitis? Well, that would depend on if we're talking about PRP or stem cell therapy as well. So happy to chat and give you a specific quotation with the patient care team, an invoice. So kind of need to know what the damage is, how severe it is, because PRP works great if it's more mild issues or mild tendinopathy, or if it's more of a larger tear, then stem cell therapy is probably going to be the best or optimal treatment of choice. So kind of need to know a little bit more specifics. All right, next question. Are there any cases of knee arthritis that wouldn't qualify for this? What would be some exclusion criteria? Yes, not everybody is a candidate for every treatment. Absolutely. When we see patients that have severe knee arthritis, we typically don't recommend PRP because the data hasn't shown for it to be a great long-term treatment option. It can help, but it's usually going to help more so in the realm of 6 months to a year. Whereas when we do a stem cell therapy for severe knee arthritis, we have printed data that shows that one treatment can be just as effective as a knee replacement and last about 15 years in about 18 to 20% of patients that have that therapy to treat their knees. Some of the things that are negative candidacy factors for knees in particular is when patients have very, very, very large bone spurs, because nothing that we're going to inject is going to dissolve or get rid of those bone spurs. When patients have significant deformity of the knee, what we call varus or valgus angulation, another common term is bow-legged or knock-kneed, where the knees are angled one way direction or the other, that can be a negative factor. Or when you've lost significant range of motion of the knee, meaning that you can no longer bend your knee past 90 degrees because it's stuck, or you can't fully extend the knee. Those can be some negative factors as well. Or patients that have had significant loss of all the ligaments of the knee. You no longer have an ACL or PCL. You have severe arthritis in every compartment. Then it's probably going to be time to consider a total knee replacement. So that's specifically for the knee, but it can vary depending on any joint in the body or for the spine. If you've already had multiple spine surgeries, then you may not be a good candidate for these treatments as well. So it just depends. Good question. Next question. If someone does the culture treatment and they return in whatever the minimum time, for example, 4 weeks, do they have to be frozen during that time? The cells, I presume. We're not freezing humans, but yes, good question. The cells are frozen during that time as well until you come back. Yes, they are cryopreserved. You can do what we call a short culture where the cells aren't necessarily frozen, when you come back in about 14 days, but the numbers are much smaller because the cells don't grow as long, and we typically don't have a lot to store for future usage. But we have used that technique a couple times, usually a couple times a year for our patients that are traveling from far and away or far abroad. I had this with a patient from Australia. So when we have patients that are coming for that long, it's not as feasible for them to come and then go for a month and come back a month later. So we have some different things that we can do for those types of patients. All right, next question. If someone has severe arthritis, how long can they feel relief or need to get another injection? Yeah, that's great. That's a great question. So like I said, there's a good study that just came out for the hips. One came out a couple of years ago for the knees, and one is pending publication for the shoulders that shows that when you have these treatments and they're done in a very precise way, meaning that we have to actually put the needle into the bone where you have arthritis, you can get up to 15 years of improvement after one treatment in almost 18 to 20% of, only about 18 to 20% of people progress to need a knee replacement or a joint replacement as well. So people can do very, very, very well after one treatment and have the same outcomes that we see with total joint replacement, whether it be knee replacement, hip replacement, et cetera. So the risks are much less. The costs are much less when you compare them comparatively to a joint replacement, and the outcomes can be just as significant after one treatment. So again, but it also depends on the wear and tear that you put on the joint. But we have several patients that have had one joint treatment 6, 7, 8, 10 years ago and are still doing well. All right, next question. Is this a definitive treatment for knee arthritis, or is it meant to delay an inevitable knee replacement? Where nothing is definitive, even a knee replacement, because a knee replacement doesn't last forever. A knee replacement on average lasts about 15 years, and you have to have another one and then another one. And each time that you have to have a subsequent knee replacement, the complication rate increases. So yes, is this an indefinite treatment that lasts until you die? Nobody knows that, but we have good data that shows that only about 15 to 20% of people have to have a knee replacement after having these treatments when they're done appropriately, and treatment is done when we treat into the bone. So, but a knee replacement is not a one size fits all and a one-stop shop. You have to have another one at some point. All right, speak on treatments for hip arthritis. Hip arthritis is a little bit different than knee arthritis. We have patients with severe hip arthritis. We typically recommend them to either get the culture expanded stem cell treatment or to have a total hip replacement. And that's for two reasons. Number one, hip replacements do the best out of every joint replacement. They have about an 85 to 90% success rate, whereas for knees, it's about 65%. And for shoulders and ankles, it's even lower than that. So that's number one. Hips do really well when they're replaced. Number two, when we have younger patients, 40s and 50-year-olds, having a hip replacement is still not ideal because you're looking at 3 hip replacements in your lifetime. So, but when you have severe hip arthritis, what we do in the United States is not as effective what we do here, because the dose or the number of stem cells that we're actually able to inject into the bone makes the outcomes about 50% better with what we do here with culturing of stem cells. So, but if we're talking about mild to moderate arthritis, having PRP or non-cultured stem cells is very reasonable and a good option. Once you have more than moderate arthritis, so moderate to severe or severe arthritis, it's going to be either a cultured stem cell treatment or hip replacement as the best treatment option for you for long-term benefit. All right, next question. What do you use, or how do you check the viability of stem cell count before an injection? We use a laboratory. We have a cell counter as well that gives us the actually viability and number of stem cells. We also send the aliquot sample of the cell to the laboratory as well to actually check them for toxins, endotoxins, and sterility to make sure those bacteria, viruses growing in the cells. And then second part of the question, are you injecting via ultrasound or live X-ray replacement? We use both. The X-ray is called fluoroscopy. We use high definition ultrasound as well. And what we use depends on what we're injecting. So when we're injecting something like the rotator cuff of the shoulder, that's primarily done with ultrasound, but we're injecting deeper joints or the labrum and things like that we can't really see that well with the ultrasound. We use the X-ray guidance. So when we're doing spine treatments, 80% of that's done with the X-ray because the spine is so deep, but we do some ultrasound injections in the spine as well. So it's usually a combination of both, but it depends on what we're treating. All right, next question. Do you have MRI imaging facilities out there? Is that done in the US prior to coming out? So both. Typically, most patients that come from the US want to use their insurance to have the insurance cover the cost of the MRI, which is absolutely reasonable. But if you want to have an MRI done out here, we do have several facilities that have 3T, which is the highest Tesla grade of an MRI that we can even do in the US. But it is much more expensive than having a cash pay MRI done in the US. On average, price is about $1,200 here for an MRI, where you can get a cash pay MRI for about $300 to $400 in the US. So I typically try to help facilitate getting those done in the US, but we do have the option to do those here if desired. All right, next question is a pre-existing spinal stimulator a contraindication for injection therapy? It's not a contraindication, but we typically need to figure out if the spinal stimulator has worked, if it hasn't worked, and then what other things have been tried. Has surgery been tried as well? But then also typically having that removed prior to treatment is an option if we're treating the lumbar spine. If we're treating something else, having a spinal cord stimulator doesn't affect the aspiration of the bone marrow or treatment of a knee per se as well. Next question, are we seeing the FDA getting close to allowing these treatments in the States? We've had no indication that there's any progress being made on that front. The FDA has been working on trying to modify their position stance on peptide therapy lately, but that's still pending on any progress as well. There are a couple of clinical trials looking at drug products that have been submitted for approval that are in phase 2 and 3 using culture expanded umbilical cells for the treatment of orthopedic issues like disc herniations. But these trials are long. One of these trials I'm mentioning started back when I was a medical student. That was back in it was going on when I was a medical student. That was in 2008 as well. So these things take a lot of time. So there is no new indications that I'm aware of. There are certain states that have looked at passing some regulations in their own state, but then it becomes more of a wild, wild west because it is illegal at the federal level. And so even if the state does take some of the red tape off, then it becomes a little bit messy of, are you doing it safely also? So not promising yet, but hopefully that may change very soon. Next question, can you have bone marrow aspiration in Baltimore, Maryland, and send it to the Caymans? Yes, in short answer, yes. The long answer is probably not logistically sound at this point. We've actually been looking into that, and we're testing some different mechanisms because the primary issue that you run into when you're shipping the bone marrow is temperature regulation, right? And then, so if it can arrive within a 24-hour period, but then have to make it through customs, and we don't want the cellular content of the bone marrow to be compromised. So we've actually done several trials with shipping bone marrow from the US, and we're tweaking some things now to make sure we can have that logistically sound so that way we can have the highest quality product available to be cultured. So yes and no, we're still tweaking that out to try to figure out the optimal way to do that. But very good question. Next question, are you able to regrow compressed vertebral disc at this time? That's a great question. Yes and no. We don't see a lot of regeneration of disc height in these treatments. What we do see when we treat for disc degeneration is healing of tearing of the disc, resolution of herniations of the disc. We can see rehydration or improvements in the water content of the disc. There's typically a lot of transient improvement in disc height, but sometimes it doesn't last. So that's not something that we can expect to be consistent as well. But all in all, patients do well. We have patients that do well for many, many years after one treatment. So great question. All right, guys. My question the new question just popped in. Next question, do stem cells also help with nerve damage? Yes, absolutely. So we treat damaged nerves all the time for multiple reasons. Some of the common nerve issues that we treat are carpal tunnel syndrome for compressed nerves in the wrist, nerves pinched or compressed in the spine as well. And then we also treat patients that have peripheral neuropathy as well also. So we treat a multitude of different nerve things. Some nerve things are not as easy to treat, but those are the primary things that we can treat. Peripheral neuropathy from compressed nerves, also nerves that are compressed or damaged centrally in the spine as well. Good question. Next question is there a specific time that must be waited before umbilical cord stem cells for doing culture stem cells from you? Yes and no. I'll always recommend you can do the harvesting of the stem cells without a time restriction, but injecting the stem cells in an area that was recently treated, I usually recommend against because you may do better or have some improvement over time. Or if there is a complication, we want that to manifest itself also. So typically the sweet spot is about 6 weeks. We can do the aspiration in the time of waiting that 6 weeks, but I always tell people wait about 6 weeks and then we can make sure there's no complications that are going to surface and to see if there's any improvement as well. Good question, but no time to wait before doing the bone marrow aspiration. Next question, what's your experience with TMJ injections as well? Oh, thank you. So we treat TMJ all the time, either in isolation or we see TMJ dysfunction in combination with cranial cervical instability or cervical instability after whiplash injuries. also. But TMJ actually responds quite well with PRP. When we are treating multiple areas, sometimes we do culture expanded stem cell therapy because it is such a small joint and you cannot get a lot of volume in that. But I've had several patients with TMJ issues with complete resolution of their clicking, their pain, their spasms as well. But TMJ does respond very well to biologic therapy. Very good question. All right. I am open for more questions. Okay, we have another one here. How many patients with knee arthritis have you treated? We've treated well over 5,000 patients for their knee arthritis at this site with culture expanded stem cell therapy as well. So we've treated quite a few patients. And I mentioned we did the first stem cell injection for knee arthritis in the world back in 2005. And we publish all of our outcomes. If you go onto our website, Cayman.ky or .com, you can go to our outcomes and it shows you how many patients that have tracked their outcomes and how they're doing over time at 1 month, 3 months, 6 months, 1 year, 2 year, 3 years, 4 years, 5 years out. And it shows you the percentage of improvement, how much their function has improved, and how much their pain has improved for multiple body parts, not just the knees, but knees, ankles, wrists, thumbs, spines. You can go on there and segment out the data and see that as well. And that's our data for our facility as well. So we try to be as transparent as possible. We know these things are not pixie dust. They don't work well for every condition, but for the right person in the right condition, it can be game changing and provide significant quality of life benefit and relief. Good question. All right, next question for intraosseous hip injections. What's the numbing protocol for the area? What's the pain relief protocol when you do the stem cell extraction in the bone marrow? Yeah, great question. So for the hip intraosseous injections, we recommend and give IV sedation because it is very painful. When we do the bone marrow aspiration or extraction, we have a suite of options available. So we can do just local numbing medicine. I've had mine done with just local numbing medicine. It's not that bad. But some people don't want to experience that. They have needle phobias and they have a preference as well. So we offer nitrous gas. We also offer conscious sedation with an IV as well, or we offer full-on deep sedation with our anesthesiologist using propofol. So we have this whole suite. It's dealer's choice. Our job is to make sure that the procedure is well tolerated and not a miserable experience for you. So we do everything. All right, next question. Can stem cells be injected into the fingers? Absolutely. Yes, I inject fingers all the time. Most commonly is the base of the thumb, as I mentioned, the CMC or carpal metacarpal joint. It's the most common joint in the body, but we treat fingers for other things. Most people get arthritis in the small finger joints, or they have sprains of ligaments around the fingers, or sometimes they have nerve issues or tendon issues as well. So yes, we commonly treat hands, fingers, wrists, and toes as well. Good question. Next question. Can you get multiple injections in the same day? Yes. I treated somebody this week where we injected their neck, their low back, hips, and knees as well, and the shoulder. So yes, that's the benefit of this treatment is because you can treat multiple areas because we've grown the cells and have enough cells to be able to do that. Whereas that's the limitation with what we do in the United States. You cannot do that without sacrificing your quality or the outcome. You're robbing Peter to pay Paul at that point. So because we have millions of stem cells, we're able to treat multiple areas at one time and also save the stem cell that we have extra as well for future and later use. Yeah, next question. Good question here. What pre-op clearance do you require? It depends on the individual. Some of the things that we recommend when we go through our telehealth visit, we go through your health history, medication and supplements, and see kind of where you are at in terms of your habitus, your quality and functional quality of life, and then make recommendations on that. If we need to get additional labs based on that conversation, then we recommend it. We always recommend people to have at least a baseline set of labs within 6 months as well, just so we can look at your liver function, your kidney function, your overall inflammatory markers. And then for patients that have specific things, there are additional clearances that may be required. So if you have a history of heart disease and you've had a CABG or a coronary artery bypass graft, or if you have a history of cancer, then we will get you in contact with your hematologist oncologist to provide a clearance letter for that. So it just depends on your medical history of what's going on, but at the very bare minimum, some labs, and then we have the conversation to kind of see what's needed beyond that. Good question. All right, next. Are there any studies for brain injections? Can you improve eyesight with these shots? Oh my, yes, there are studies that have done stem cell therapy post-stroke patients into the brain and also into the spinal cord for patients that have had spinal cord injury. We do not dibble and dabble into that. As well in eyesight, there are several studies that have been done looking at improvement of eyesight for conditions like glaucoma and macular degeneration with stem cell therapy. That's not something that we get into. The closest thing that we treat for eyesight issues is for patients with cranial cervical instability that have blurry vision that's related to their neck. And treating and stabilizing the structures in their neck actually helps their visual issues out as well. But good question. And if you are interested in some of those things like brain or eye injections, if you go to clinicaltrials.gov and put in whatever, it'll kind of prompt you to put in stem cell therapy. You can put that in the condition, say macular degeneration, and it'll provide you a list of clinics or research trials that may be treating those different conditions throughout the world as well. All right. I'm out of questions, and it's 1 p.m. I definitely appreciate everybody's time and great questions that you have had for me as well. So thank you so much. We will get you guys all a copy of this audio visual presentation. It'll have the Q&A included in there as well. And please reach out to us to schedule a telehealth consult so we can talk to you specifically about your issue. Or if you have any questions, I'm more than happy to chat with you as well. We also have an option. If you email us, I can also review your information and images via email also, whatever is convenient. I'm happy to help. Thanks so much, and please be safe, guys.